Hello everyone, and welcome back to another chapter of Advanced Pharmacology. Today in Unit 14, Drugs for Bone and Joint Disorder, we're speaking specifically on Chapter 57, Drug Therapy of Rheumatoid Arthritis. Rheumatoid arthritis, also known as RA, is an autoimmune inflammatory disorder that affects about 1% of the American population. Each year, the disease results in more than 9 million physician visits and more than 250,000 hospitalizations. Although rheumatoid arthritis can develop at any age, initial symptoms usually appear during the third or fourth decade. Among the younger patient population, the incidence of rheumatoid arthritis in females is 3 times greater than in males. However, among the patient older than 60, the incidence in men and women is roughly equal. Rheumatoid arthritis follows a progressive course and can eventually cause joint deformities and functional limitations. In many cases, drug therapy can delay disease progression. In others, benefits are limited to symptomatic relief. Some of the drugs used for RA were introduced in preceding chapters. Additional drugs are introduced here. So, the pathophysiology of rheumatoid arthritis. Onset of rheumatoid arthritis is heralded by symmetrical joint stiffness and pain. Symptoms are most intense in the morning and abate as the day advances. Joints become swollen, tender, and warm. Some patients, periods of spontaneous remission occur. For others, injury progresses steadily. In addition to joint injury, rheumatoid arthritis has systemic manifestations, including fever, weakness, fatigue, weight loss, thinning of the skin, scleritis, corneal ulceration, vasculitis, and nodules under the skin and periosteum. The progression of joint deterioration is shown in Figure 57.1. Inflammation begins in the synovium, the membrane that encloses the joint cavity. As inflammation intensifies, the synovial membrane starts to thicken and begins to envelop the articular cartilage. This overgrowth is referred to as a pannus. Damage to the cartilage is caused by enzymes released from the pannus and by chemicals and enzymes produced by the inflammatory process raging within the synovial space. Ultimately, the articular cartilage undergoes total destruction, resulting in direct contact between the bones of the joint, followed by the eventual bone fusion. After this, inflammation starts to subside. So here's a good spot to hit pause so you can see a picture version of what I just said. Joint destruction is caused by an autoimmune process in which the immune system mounts an attack against synovial tissue. During the attack, mast cells, macrophages, and T lymphocytes start to produce cytokines and cytotoxins, compounds that promote inflammation and joint destruction. The cytokines of the greatest importance are the tumor necrosing factor, interleukin 1, 6, interferon gamma, platelet-derived growth factor, and granulocyte macrophages colony stimulating factor. So, why the immune system attacks the joints, however, is still considered unclear. The overview on therapy. Treatment is directed at first, relieving symptoms of pain, inflammation, and stiffness. Second, maintaining joint function and range of motion. Third, minimizing systemic involvement. Fourth, delaying the disease progress. To achieve these goals, a combination of pharmacologic and non-pharmacologic measures are used. So, non-drug measures. Non-drug measures for managing rheumatoid arthritis include physical therapy, exercise, and surgery. Physical therapy may consist of massage, warm baths, and applying heat to the affected regions. The procedures can enhance mobility and reduce inflammation. A balanced program of rest and exercise can decrease joint stiffness and improve function. However, excessive rest and excessive exercise should be avoided. Too much rest will foster stiffness, and too much activity can intensify inflammation. Orthopedic surgery has been marked and has made advances. For patients with severe disease of the hip or knee, total joint replacement can be performed. When joints of the hand and wrist have been damaged severely, function can be improved through the removal of the diseased synovium and repair of ruptured tendons. Plastic implants can also help correct some of the deformities. A complete program of treatment should include patient education and counseling. The patient should be informed about the nature of rheumatoid arthritis, the possible consequences of joint degeneration, management measures, and the benefit and limitation of drug therapy. If loss of mobility limits function at home, on the job, or in school, consultation with a social worker, occupational therapist, or specialist in vocational rehabilitation may be appropriate. Drug therapy. Anti-arthritic drugs can produce symptomatic relief, and some drugs, if started very early in the disease process, can induce protracted remission. However, remission is rarely complete, and the disease typically advances steadily. As a result, drug therapy is chronic, and hence success requires patient motivation as well as cooperation. So classes of anti-arthritic drugs. The anti-rheumatic drugs fall into three major categories: are nonsteroidal anti-inflammatories, glucocorticoids, and disease-modifying anti-rheumatic drugs. These major groups differ with respect to time course of effects, toxicity, and their ability to slow rheumatoid arthritis' progression. NSAIDs provide relief that is rapid of symptoms, but do not prevent joint damage and do not slow disease progression. NSAIDs are safer than DMARDs and glucocorticoids. Therefore, treatment with NSAIDs require less rigorous monitoring. Similar to NSAIDs, glucocorticoids provide rapid relief of symptoms. In addition, they can also slow disease progression. Unfortunately, although glucocorticoids are effective, with long-term use they can cause serious toxicity, so as a result, treatment is usually limited to short courses. By definition, DMARDs are drugs that reduce joint destruction and slow disease progression. However, benefits develop more slowly than with NSAIDs. The DMARDs are more toxic than NSAIDs, and therefore close monitoring is required. In the discussion that follows, DMARDs are subdivided into two basic groups: non-biologic DMARDs and biologic DMARDs, based on their molecular size and method of production. The non-biologic DMARDs are a small molecule that are synthesized using conventional chemical techniques. In contrast, the biologic DMARDs are large molecules that are produced through recombinant DNA technology. Drug selection. Management of rheumatoid arthritis is overseen by a rheumatologist and other specialists. DMARDs, in particular, are associated with significant effects and are sometimes dangerous risks. Lifespan considerations are a special concern. So here's an excellent spot to hit pause to see patient-centered care across the lifespan. Management of rheumatoid arthritis is aggressive. Current guidelines recommend starting a DMARD early, within 3 months of a rheumatoid arthritis diagnosis, for most patients. The aim is to delay joint degeneration. Recall that NSAIDs only provide symptomatic relief. They do not slow disease progression. In contrast, DMARDs may be able to arrest the disease process. By instituting DMARD therapy early, rather than waiting until joint degeneration has advanced to the point at which NSAIDs can no longer control the symptoms, it is possible to delay or even prevent serious injury. So here is a perfect time to hit pause so that you can see the algorithm for the rheumatoid arthritis management. Because the effects of DMARDs take weeks or even months to develop, whereas the effects of NSAIDs are immediate, an NSAID is given until the DMARD has had time to act, after which the NSAID can be withdrawn. As in the past, glucocorticoids are generally reserved for short course management of symptom flare-ups and to help control symptoms until DMARDs have taken full effect. If joint injury progression despite treatment with an initial DMARD, another DMARD can be added or substituted. You can find all the detailed information on pharmacologic management of rheumatoid arthritis in clinical guidelines sponsored by the American College of Rheumatology. So here's an excellent spot to hit pause, and you can take a look at their website here at rheumatology.org. Which brings us to nonsteroidal anti-inflammatory drugs. The basic pharmacology of NSAIDs are discussed in Chapter 55. Consideration here is strictly limited to their role in rheumatoid arthritis. Their therapeutic role. NSAIDs are prescribed for their anti-inflammatory and analgesic action. Both actions result from inhibiting cyclooxygenase. NSAIDs only provide symptomatic relief. They do not slow disease progression. Accordingly, they are usually combined with a DMARD. Non-steroidal anti-inflammatory drug classification. There are two main classes of NSAIDs. The first generation, which inhibit COX-1 as well as COX-2, and second generation NSAIDs, which selectively inhibit COX-2. Anti-inflammatory and analgesic effects result from inhibiting COX-2, whereas major adverse effects, especially gastroduodenal ulceration, result from inhibiting COX-1. Therefore, the selectivity of the drug class results in less gastrointestinal ulceration than the first generation NSAIDs, while producing equal therapeutic effect. So, drug selection. Selection of an NSAID is based largely on efficacy, safety, and cost. Efficacy. All of the NSAIDs have essentially the equal anti-rheumatic effect. However, individual patients may respond better to one NSAID than to another. Accordingly, it may be necessary to try more than one agent to achieve an optimal response. Safety and cost. All prescription strength NSAIDs carry a boxed warning regarding risk for thrombotic events and GI ulceration as well as bleeding. Although the risk for GI problems is less with a COX-2 inhibitor, the risk for thrombotic events may be increased because COXIPs inhibit COX-1 to a far lesser degree than traditional NSAIDs. Selection must be balanced these factors. COXIPs are the most expensive than traditional NSAIDs. If symptoms are controlled with the first generation NSAIDs and the drug is well tolerated, cost considerations will dictate using that drug. Again, however, if a first generation NSAID produces serious gastric ulceration and the patient is at low risk for thrombosis, then switching to celecoxib might be appropriate despite the increased cost. So that brings us to dosage. Dosage employed for anti-inflammatory effects are considerably higher than those required for analgesia or fever reduction. For example, treatment for rheumatoid arthritis may require 5.2 grams or 16 standard tablets of aspirin a day, compared with the 2.6 grams for aches, pains, and fevers. The following dosages for rheumatoid arthritis are shown in the following table. So here's an excellent spot to hit pause and take a look at different first and second generation NSAIDs and their dosages. Glucocorticoids. The glucocorticoids are powerful anti-inflammatory drugs that can relieve symptoms of severe rheumatoid arthritis and may also delay disease progression. For patients with generalized symptoms, oral glucocorticoids are indicated. However, if only one or two joints are affected, intra-articular injections may be employed. Because long-term oral therapy can cause serious toxicity, short-term therapy should be used whenever possible. Most often, glucocorticoids are used for temporary relief until drugs with more slowly developing effects can provide control. They may also be employed for flares, which are disease exacerbations that occur in patients whose condition were previously controlled. Long-term therapy should be limited to patients who have failed to respond adequately to all other options. The pharmacology of glucocorticoids is discussed in Chapter 56. So, that brings us to the non-biologic disease anti-modifying rheumatoid drugs. As noted, the non-biologic DMARDs are small molecules produced using conventional synthetic procedures. With several of these drugs, benefits result from immunosuppression. Unlike the NSAIDs, whose benefits are limited to symptomatic relief, the non-biologic DMARDs can slow disease progression. These drugs are potentially more harmful than NSAIDs, and clinical responses develop more slowly. The non-biologic DMARDs cost much less than biological DMARDs, largely because the non-biologic agents are easier to make. That brings us to the first medication here, methotrexate. Methotrexate, also known as Rheumatrex or Trexal, acts faster than all other DMARDs. Therapeutic effects may develop in 3 to 6 weeks. At least 80% of patients improve with this drug. Benefits are the result of immunosuppression, secondary to reducing the activity of B and T lymphocytes. Many rheumatologists consider methotrexate the DMARD of first choice, owing to its efficacy, relative safety, low cost, and extensive use in rheumatoid arthritis. Major toxicities are hepatic fibrosis, bone marrow suppression, GI ulceration, and pneumonitis. Periodic tests of liver and kidney function are mandatory, as are complete blood cell counts and platelet counts. Methotrexate can cause fetal death and congenital abnormalities, and therefore is contraindicated during pregnancy. Recent data suggest that patients using methotrexate for rheumatoid arthritis may have a reduced life expectancy owing to increased deaths from cardiovascular disease, infection, and certain cancers. For treatment for rheumatoid arthritis, methotrexate is administered once a week, either orally or via injection. Dosing with folic acid is recommended to reduce the GI and hepatic toxicity. So that brings us to its black box warning. Methotrexate can cause numerous and potentially fatal toxicities of the bone, marrow, liver, lungs, and kidneys. Other fatalities have occurred associated with skin reactions and due to hemorrhagic enteritis and gastrointestinal perforation. Which brings us to our sulfasalazine, also known as sulfididine, which has been used for decades to treat inflammatory bowel disease. Benefits for RA result from anti-inflammatory and immunomodulatory actions. In patients who have rheumatoid arthritis, sulfasalazines can slow the progression of joint deterioration, sometimes with just 1 month of treatment. Gastrointestinal reactions, such as nausea, vomiting, diarrhea, abdominal pain, and anorexia, are the most common reasons for stopping treatment. These reactions can be minimized by using an enteric-coated formulation and by dividing the daily dosage. Dermatologic reactions such as pruritus, rash, and urticaria are also common. Fortunately, serious adverse effects, hepatitis and bone marrow suppression, are considered rare. To ensure early detection, periodic monitoring for hepatitis and bone marrow function should be performed. Because of its structure, sulfasalazine should not be prescribed for patients with a sulfa allergy. Sulfasalazine will be discussed further in Chapter 64. Which brings us to leflunomide. Leflunomide is a powerful immunosuppressant indicated for adults who have active rheumatoid arthritis. In clinical trials, the drug decreased signs and symptoms and slowed disease progression. Compared with methotrexate, leflunomide is about equally effective, but is potentially more hazardous and much more expensive. Accordingly, the drug is often reserved as a second-line use. Leflunomide is a prodrug that undergoes conversion to its active form, metabolite 1, in the body. M1 inhibits the dihydroorotate dehydrogenase, a mitochondrial enzyme needed for de novo synthesis of pyrimidines, which in turn are needed for T cell proliferation and antibody production. In vitro, leflunomide inhibits T cell proliferation. In animals, it suppresses inflammation. So its pharmacokinetics. After an oral dose, leflunomide is converted to M1 by enzymes in the intestine and liver. Levels of M1 peak in 6 to 12 hours, and the active form undergoes further metabolism, followed by the excretion in urine and bile. The half-life is prolonged to 16.5 days, so as a result, a series of loading doses is needed to achieve steady state quickly. It does come with some adverse effects. The most common adverse effects occur in at least 10% of patients: diarrhea, respiratory infections, reversible alopecia, and a rash. The drug has also been associated with much more serious reactions, including pancytopenia, Stevens-Johnson syndrome, and severe hypertension. Leflunomide is hepatotoxic. Elevation of liver enzymes occurs in about 10% of patients. In post-marketing reports, the drug has been associated with more than 130 cases of severe liver injury, including 14 that were fatal. Liver function should be assessed at baseline, every month for the first 6 months of treatment, and then every 6 to 8 weeks thereafter. Leflunomide should be avoided in patients who have liver impairment, hepatitis B or C. Patients should be informed about signs of liver injury, which includes our abdominal pain, fatigue, dark urine, and jaundice, and be advised to report them immediately. Leflunomide may increase the risk for serious infections. The drug is immunosuppressive and can suppress the bone marrow. Rarely, patients experience sepsis and other severe infections, including tuberculosis. Deaths have occurred. If an infection develops, it may be necessary to interrupt leflunomide use. To reduce risk, platelet count and blood cell count should be conducted at baseline every month for the first 6 months of treatment and then every 6 to 8 weeks thereafter, much like the liver function test. If evidence of bone marrow suppression is detected, leflunomide should be discontinued. Patients should be screened for tuberculosis before starting this drug. Leflunomide is carcinogenic in animals, but has not been associated with any kind of cancer in humans at this time. Leflunomide in pregnancy. Uh, Leflunomide is contraindicated during pregnancies. Patients who wish to become pregnant must first clear leflunomide from the body. A 3-step protocol is followed, starting off with stopping the medication. Second, take cholestyramine, 8 grams 3 times a day for 11 days. Cholestyramine binds leflunomide and its metabolites in the intestines, accelerating their excretion. Without cholestyramine, safe levels may not be achieved for up to 2 years. Step 3, verify that the plasma drug level is below 20 micrograms per liter. To minimize any risk for potential fetal injury, men who use leflunomide who wish to father a child should undergo that same clearance procedure. It does have drug interactions as well. Leflunomide can inhibit the metabolism of certain NSAIDs, causing their levels to rise. In addition, leflunomide can intensify liver damage from the other hepatotoxic drugs, and therefore should not be combined with such agents. Rivampin, which is a drug used for tuberculosis, can raise leflunomide levels by up to 40%. Conversely, 2 other agents, cholestyramine and activated charcoal, can rapidly lower leflunomide levels. Which brings us to hydroxychloroquine, also known as Plaquenil. A drug with an antimalarial action is considered preferred DMARD in the 2015 ACR treatment guideline. So, how hydroxychloroquine works in rheumatoid arthritis is considered still unknown. As a rule, the drug is usually combined with methotrexate. By itself, hydroxychloroquine does not slow disease progression, but early use can improve long-term outcomes. Hydroxychloroquine should be taken with food or milk. Concurrent therapy with an anti-inflammatory agent such as NSAIDs or glucocorticoids is indicated during the latency period. Retinal damage, which is considered rare, is the most serious toxicity. Retinopathy may be irreversible and can produce blindness. Visual loss is directly related to the dosage. Low doses may be used in long-term treatment with very little risk. When dosage has been excessive, retinal damage may appear after treatment has ceased and may progress in the absence of continued drug use. Patients should undergo a thorough ophthalmologic examination before treatment and every 6 months thereafter. Hydroxychloroquine should be discontinued at the first sign of any kind of retinal injury. Patients should be advised to contact the prescriber if any kind of visual disturbances are noted. Bringing us to other non-biologic disease-modifying anti-rheumatic drugs. So, several drugs that are FDA approved for rheumatoid arthritis are used infrequently, largely because of their adverse effects. Some of the medications, such as azathioprine, cyclosporins, minocycline, and gold, are no longer recommended. However, they may still be used as a last resort when other drugs fail to meet therapeutic objectives. These drugs are discussed briefly here. Penicillamine, also known as supramine or Depin, can relieve symptoms of rheumatoid arthritis and can delay disease progression. Unfortunately, treatment may be associated with a serious toxicity, especially bone marrow suppression and autoimmune disorders. Because it is associated with fatalities, penicillamine use should be restricted to cases where rheumatoid arthritis is severe and unresponsive to other treatment. Therapeutic effects take 3 to 6 months to develop. Gould salts, auranofin, or Ridora, have been used for rheumatoid arthritis for decades. Treatment can relieve pain and stiffness, and may also delay disease progression. The mechanism underlying these benefits is still considered unknown. Unfortunately, adverse effects are common. Potential reactions include intense pruritus, rashes, stomatitis, kidney damage, severe blood dyscrasias, encephalitis, hepatitis, peripheral neuritis, pulmonary infiltrates, and profound hypotension. So, it's black box warning on auranofin or Ridora. Gould compounds can cause gold toxicity, manifested by serious blood dyscrasias, stomatitis, profuse diarrhea, proteinuria, hematuria, and rash. Which brings us to azathioprine, also known as Imuran, is an older DMARD with immunosuppressive and anti-inflammatory actions. Serious toxicities include hepatitis and blood dyscrasias. The drug may also pose a small risk for malignancies. Cyclosporines, an immunosuppressive drug used to prevent rejection of transplanted organs, can also reduce symptoms of RA. Because it can cause kidney damage and other serious adverse effects, cyclosporine should be reserved for severe progressive RA that has not responded to safer DMARDs. In patients with an inadequate response to methotrexate, adding cyclosporine may produce significant improvement. Minocycline. Minocycline, an antibiotic in the tetracycline family, has been used experimentally in rheumatoid arthritis management. It can improve morning stiffness, joint pain and tenderness, and activities of daily living. In addition, it may delay disease progression in some patients. The precise mechanism by which it accomplishes this is still unknown. The ACR did not include minocycline in the 2015 guidelines because of its infrequent use and the lack of new data since 2012. Protein A column, Prosorba. The Prosorba column, used in combination with plasmapheresis, decreases the titer of circulating immune complexes that promote symptoms of RA. A column contains an absorbent compound, protein A, which binds to antibodies of the immunoglobulin G or IgG class and to the IgG antigen complexes. When the patient's plasma is passed through the column, these antibodies and immune complexes are removed. Treatment should be reserved for patients with moderate to severe RA who have been refractory to or intolerant of methotrexate, and other DMARDs. The most common adverse effects are transient increases in joint swelling, joint pain, and fatigue. Which brings us now to the biologic disease modifying anti-rheumatic drugs. The biologic DMARDs are immunosuppressive drugs that target specific components of the inflammatory process. These drugs are usually combined with methotrexate. Of the biologic agents available, only 7 are used routinely. 5 of these, etanercept, infliximab, adalimumab, golimumab, and certolizumab, PIGL, interfere with TNF, or tumor necrosing factor. One agent, rituximab, promotes destruction of B lymphocytes, and one agent, abatacept, inhibits activation of T lymphocytes. Because these drugs suppress immune function, they all pose a serious risk for serious infections and possible cancers. As noted, the biologic DMARDs are so named because they are manufactured using recombinant DNA technology, an expensive process that reflected in the cost of these drugs, which can range between $14,000 to $65,000 annually. Which brings us to the disease-modifying anti-rheumatic drugs listed on table 57.2, an excellent spot to hit pause so you can look at all the major and minor drugs. Your tumor necrosing factor antagonists. The drugs in this group work by neutralizing tumor necrosing factor, an important immune mediator of joint injury. In rheumatoid arthritis, 5 TNF antagonists are available. In patients with RA, all 5 are highly and equally effective. Unfortunately, all 5 pose a risk for serious infection, including bacterial sepsis, invasive fungal infections, hepatitis B infections, and tuberculosis. Rarely, patients experience severe allergic reactions, heart failure, liver failure, hematologic disorders, neurologic disorders, or cancers. The principal differences among these drugs concern dosing schedule and the route of administration. In addition to their use in RA, these drugs are approved for other inflammatory disorders, which include psoriatic arthritis, ankylosing spondylitis, and Crohn's disease. So this next table here is another good spot to hit pause so you can see the approved indications for tumor necrosing factor antagonists and why or when you would use them for each of the following diseases. Starting us off here now with etanercept. Etanercept was the first TNF antagonist available, and it will serve as our prototype for the drug group. Like all other TNF antagonists, etanercept is highly effective at reducing RA symptoms and disease progression, but may also promote serious infections and other adverse effects. So here was our prototype drugs. A good spot to hit pause to review those, but we'll keep going with it. So how does etanercept work? Its mechanism of action suppresses inflammation by neutralizing tumor necrosing factor. Again, as noted earlier, tumor necrosing factor is an important contributor to RA pathophysiology. In patients with rheumatoid arthritis, tumor necrosing factor binds with receptors on the cells in the synovium and thereby stimulates production of chemotactic factors and endothelial adhesion molecules, which in turn promote infiltration of neutrophils and macrophages. The result is inflammation and joint destruction. So how does etanercept neutralize TNF? Etanercept is a large molecule composed of 2 receptors for TNF that are linked to the Fc component of IgG. The TNF receptors, which are produced through recombinant DNA technology, are identical to the TNF receptor found on human cells. Like the TNF receptors on our cells, etanercept binds tightly with TNF and thereby prevents TNF from interacting with its natural receptors on cells. So its therapeutic use. It is indicated for a patient with moderate to severe active rheumatoid arthritis. In clinical trials, the drug was slightly superior to methotrexate at delaying progression of joint damage, and it suppressed signs and symptoms of RA more rapidly. Among patients who had failed to respond to methotrexate, addition of etanercept for 6 months reduced symptoms by up to 61%, compared with 27% who continued taking methotrexate alone. In addition to RA, etanercept is approved for ankylosing spondylitis, plaque psoriasis, psoriatic arthritis, and juvenile idiopathic arthritis. So, its pharmacokinetics. Etanercept is administered by a subcutaneous injection. Plasma levels peak in about 3 days after dosing. The drug is cleared from the plasma with a half-life of 115 or 5 days, and the mode of elimination is considered unknown. One hypothesis is that metabolism of the bound TNF drug complex takes place through peptide or amino acid degradation, after which elimination of metabolites takes place in the bile or urine, while amino acids are recycled. So, its adverse effects. Well, it starts off with a big black box warning. TNF antagonists are at increased risk for developing serious systemic infections, including sepsis. Children and adolescents taking TNF antagonists have developed lymphoma and other malignancies. But it also has mild effects. Injection site reactions include itching, erythema, swelling, pain, which occur in 37% of patients, but usually subside in a few days. Other mild but less common reactions include headaches, rhinitis, dizziness, cough, and abdominal pain. More serious infections, however, increases the risk by using etanercept, including invasive fungal infections and infections caused by Mycobacterium tuberculosis and other opportunistic pathogens, including Legionella pneumophila and Listeria monocytogenes. So why do these infections develop under normal conditions? TNF plays a crucial role in our immune response to infections, especially those caused by tuberculosis and other intracellular pathogens. Accordingly, when we neutralize therefore TNF with etanercept, the risk for infection goes up. Infection risk is further increased by diabetes, HIV, and concurrent use of immunosuppressant drugs, including glucocorticoids and methotrexate. Tuberculosis is a special concern on its own. When TB develops in patients taking etanercept, the disease is often extrapulmonary and disseminating. To reduce the risk, potential users should be tested for latent TB, and if the test is positive, should undergo TB treatment before etanercept is started. During etanercept's treatment, patients should be monitored closely for TB development. Etanercept may also promote reactivation of latent infections, which include hepatitis B. Fatalities have occurred, and candidates for etanercept therapy should be tested for latent HBV, and those who test positive should be again monitored closely. If reactivation of HBV infection occurs, etanercept should be stopped and the patient be given antiviral drugs. To reduce the risk for infections, etanercept should not be given to a patient with an active infection, including infections that are chronic or localized. Patients who develop a new infection should be monitored closely. Etanercept should be used with caution in patients with a history of recurrent infections or any condition that predisposes them to acquiring an infection. If a severe infection does develop, etanercept should be discontinued. Severe allergic reactions. Well, rarely etanercept has been associated with any kind of severe allergic reaction, including Stevens-Johnson syndrome, erythema multiforme, and toxic epidermal necrolysis. The median onset of symptoms is known in cases was 28 days after the starting etanercept. Patients and providers should be alert for these reactions. Heart failure. The medication may pose a risk for heart failure. In patients who are using the drug, existing cases of heart failure have gotten worse, and new cases started to develop. Exercise caution in patients with existing heart failure and monitor them closely for disease progression. Cancer. Etanercept and other TNF antagonists may increase the risk for lymphoma and other malignancies, primarily in children, adolescents, and young adults. Hematologic disorders. Etanercept may pose a small risk for hematologic disorders, which include neutropenia, thrombocytopenia, and aplastic anemia, which can be fatal. Advise patients who develop signs or symptoms of the blood disorder to seek immediate medical attention. If a significant hematologic abnormality is diagnosed, discontinuing etanercept should be considered. Liver injury. Rarely, etanercept has been associated with any kind of severe liver injury, including acute liver injury and failure. Some patients have required a liver transplant, and some have died. Patients should be informed about symptoms of liver injury: fatigue, yellow skin, yellow eyes, anorexia, right-sided abdominal pain, dark brown urine, and advised to seek medical attention if these signs or symptoms start to develop. If severe liver injury is diagnosed, discontinuation of etanercept should be considered. Etanercept should be used with caution in patients who have pre-existing liver dysfunction. Your CNS demyelinating disorder. Etanercept has been associated with rare cases of CNS demyelinating disorders, which include multiple sclerosis, myelitis, and optic neuritis. However, a causal relationship has not been established. Nonetheless, caution is advised, especially in a patient with a pre-existing or recent onset of demyelinating disorder. Drug interactions. By neutralizing TNF, etanercept may increase the risk for acquiring or transmitting infection after immunization with a live virus vaccine. Accordingly, the live virus vaccine should be avoided. In pediatric patients, vaccinations should be up to date before starting the drug. Immunosuppressant drugs, including glucocorticoids, methotrexate, tocilizumab, anakinra, and abatacept, increase the risk for serious infection. Use these combinations with severe caution. Finally, preparation, dosage, and administration of etanercept and other DMARDs are provided here in the following table. So here's a good spot to hit pause so you can look at all the different dosages and preparations and how we would administer them. I'm now trying to make it make sense as to where to pause. So here's a good spot, and then I'll go down a little further. Which brings us to our next medication, infliximab. Infliximab, also known as Remicade, formulated for IV use, was the second TNF antagonist approved for RA. Like etanercept, infliximab binds to and thereby neutralizes TNF. However, the two drugs are structurally different. Where etanercept is composed of two TNF receptors, infliximab is a TNF antibody. In patients who have RA, infliximab is approved for combined use with methotrexate to reduce symptoms and delay disease progression. Infliximab is also approved for psoriasis, psoriatic arthritis, ankylosing spondylitis, and two intestinal disorders, both ulcerative colitis and Crohn's disease. It does come with adverse effects. Infliximab has immunosuppressant actions that can increase the risk for serious infections, including bacterial sepsis, invasive fungal infections, HPV infections, and TB. Accordingly, the drug should not be given to a patient with chronic infections and should be temporarily withdrawn if an acute infection develops. Patients should receive a TB test and HPV test to rule out latent infection before treatment. Like other TNF inhibitors, infliximab has been associated with rare cases of heart failure, liver failure, hematologic disorders, neurologic disorders, severe allergic reactions, and cancers. Infliximab is administered by slow IV infusion. Infusion reactions are common, manifesting as flu-like symptoms: headache, fever, chills, dyspnea, hypotension, skin reactions, and GI disturbances. Rarely, patients experience anaphylaxis. Symptoms can be reduced by pretreatment with an antihistamine, Tylenol, or glucocorticoid. Mild reactions can be managed by slowing or interruption of the infusion. If anaphylaxis develops, the infusion needs to be stopped. Which brings us to adalimumab. also known as Humira, which is a monoclonal antibody that binds to and thereby neutralizes TNF. The drug is indicated for adults with moderate to severe RA who have not responded adequately to one or more DMARDs. In these patients, Humira can reduce symptoms and slow progression of joint damage. The drug can be used alone or in combination with methotrexate or other DMARDs. In addition to RA, Humira is approved for ankylosing spondylitis, juvenile idiopathic arthritis, plaque psoriasis, psoriatic arthritis, Crohn's disease, and ulcerative colitis. Humira is generally well tolerated. The most common side effect is an injection site reaction, rashes, erythema, itching, pain, and swelling, which develop in about 20% of patients. Similar to other TNF inhibitors, Humira can promote serious infections, bacterial sepsis, invasive fungal infections, TB, and HPV, and has been associated with rare cases of heart failure, liver failure, hematologic disorders, neurologic disorders, severe allergic reactions, including cancer. Which brings us to golimumab, also known as Simponi, which is approved for RA, but only in combination when taken with methotrexate. Similar to infliximab, golimumab is a monoclonal antibody that binds with and thereby neutralizes TNF. In addition to RA, golimumab is approved for the treatment of ulcerative colitis, ankylosing spondylitis, and psoriatic arthritis. During clinical trials, the most common adverse effect was an injection site reaction, upper respiratory tract infections, and nasopharyngitis. However, except for injection site reactions, the incidence of these adverse effects was only slightly higher than in patients who received the placebo. Like other TNF inhibitors, golimumab can promote serious infections and has been associated with rare cases of heart failure, liver failure, hematologic disorders, neurologic disorders, severe allergic reactions, and cancers. Which brings us to certolizumab pegol, also known as Cimzia, which is another monoclonal antibody derivative designed to neutralize TNF. The drug consists of a recombinant humanized Fab antibody fragment that has been covalently bound to polyethylene glycol. Because of this pegation, the drug is eliminated slowly, with a half-life of 17 days. Cimzia is approved for treatment of adults with moderate to severe RA, Crohn's disease, ankylosing spondylitis, and psoriatic arthritis. In patients with RA, the combination of certolizumab plus methotrexate was more effective than the medication certolizumab alone. Rituximab, a B lymphocyte depleting agent. So how does it work? Rituxan, or rituximab, reduces the number of B lymphocytes, cells that play an important role in the autoimmune attack on joints. So as a result, rituximab can reduce symptoms of RA and slow disease progression. But how does it work? Rituximab is a monoclonal antibody directed against the CD20, an antigen found exclusively on the surface of B lymphocytes. When rituximab binds with CD20, the immune system attacks the rituximab B cell complex, causing a B cell lysis and therefore its death. Rituximab, in combination with methotrexate, is indicated for IV therapy of adults with moderate to severe RA who have not responded to one or more TNF antagonists. In addition, rituximab is indicated for two inflammatory disorders of blood vessels, Wegener granulomatosis and microscopic polyangiitis, and for two types of cancers, the B-cell non-Hodgkin's lymphoma and B-cell chronic lymphocytic leukemia. So what adverse effects do we see? Well, infusion reactions are the most common, which can cause severe infusion-related hypersensitivity reactions, beginning within 30 to 120 minutes. The immediate reaction and its sequelae include hypotension, bronchospasms, angioedema, hypoxia, pulmonary infiltrates, myocardial infarctions, and cardiogenic shock. Deaths have occurred within 24 hours. To reduce the risk of these events, patients should be pre-medicated with an antihistamine and Tylenol and monitored during the infusion. If a severe reaction does occur, management includes giving glucocorticoids, epinephrine, bronchodilators, and oxygen. Mucocutaneous reactions. Rituximab has been associated with severe mucocutaneous reactions, including Stevens-Johnson syndrome, lichenoid dermatitis, vesiculobullous dermatitis, and TEN. Deaths have occurred. Reaction onset is typically in 1 to 3 weeks after rituximab exposure. Patients who experience these reactions should seek immediate medical attention and should not receive rituximab again. Hepatitis B reactivation. There have been reports of an HBV reactivation leading to fulminant hepatitis, hepatic failure, and death. Patients at high risk for HBV should be screened before getting rituximab. Asymptomatic carriers should be closely monitored for clinical and laboratory signs of active HBV infection while taking rituximab for several months after stopping. Progressive multifocal leukoencephalopathy, also known as PML. Rituximab has been associated with rare cases of PML, a severe infection of the CNS caused by the reactivation of the JC virus, an opportunistic pathogen resistant to all available drugs. Most cases have occurred in patients being treated for non-Hodgkin's lymphoma. Patients and prescribers should be alert for any new neurologic signs and symptoms. If PML is diagnosed, rituximab should be discontinued immediately. Other adverse effects, like other monoclonal antibodies, rituximab can cause a flu-like syndrome, especially during the initial infusion. Symptoms include fever, chills, nausea, vomiting, and myalgia. Rituximab causes transient neutropenia, but this does not appear to increase the risk for infection. So, its preparation, dosage, and administration. Well, rituximab is supplied in a solution in a 10 and 50 ml single-use vial. The concentration solution should be diluted in normal saline or D5% dextrose in water to a final concentration of 1 to 4 milligrams per ml and then be administered by IV infusion. Again, to reduce the risk for infusion reactions, patients should be premedicated with an antihistamine and Tylenol. Premedication with an IV corticosteroid, such as methylprednisolone, is also recommended with patients who have RA. Abatacept, a T-cell activator inhibitor, also known as Orencia, is the first-in-class T-cell activation inhibitor, reduces symptoms of RA and disease progression. Patients who have not responded adequately to methotrexate or TNF antagonists have experienced significant improvement with the drug. Like other biologic DMARDs, abatacept poses a risk for serious infection and may also pose a small risk for cancer. Its therapeutic use, therefore, abatacept has 2 approved indications: to reduce symptoms and delay disease progression in adults with severe to moderate active RA, and to decrease symptoms of moderately to severely active polyarticular juvenile idiopathic arthritis in children 6 years and older. For the adult population with RA, abatacept may be used alone or in combination with most other DMARDs, but not with any TNF antagonist or anakinra. For children with juvenile idiopathic arthritis, the drug may be used alone or in combination with methotrexate. So how does it work? Well, in patients with RA, activated T lymphocytes play a key role in the autoimmune attack on joints. Abatacept prevents T-cell activation. For T-cells to achieve full activity, they must be stimulated by antigen-presenting cells. Abatacept, a complex molecule composed of a ligand linked to IgG1, binds with receptors of APC and thereby prevents the APCs from activating the T-cells. The results are reduced T-cell proliferation and reduced production of interferon gamma interleukins, and TNF. So what kind of adverse effects do we see? Abatacept is generally well tolerated. The most common adverse effects are headaches, upper respiratory infections, nasopharyngitis, and nausea. Because abatacept suppresses immune function, the drug can increase the risk for serious infections, such as pneumonia, cellulitis, bronchitis, diverticulitis, pyelonephritis, and UTIs. Patients should be told about these infection risks and be advised to report suspected infection immediately. If a serious infection does develop, abatacept should be discontinued. Abatacept may blunt the effects of all vaccines and may increase the risk for infection from live virus vaccines. Before abatacept is given to children, all vaccinations should be already up to date. Live virus vaccines should not be used in children or adults during abatacept use and for 3 months after stopping. Drug interactions. Abatacept should not be used in any kind of conjunction with any TNF antagonist. The combination increases the risk for serious infection and offers no benefit over abatacept alone. Which brings us now to tocilizumab, an interleukin-6 receptor antagonist. In patients with RA, interleukin-6 helps amplify the autoimmune attacks on joints. Accordingly, drugs that block the actions of interleukin-6 can therefore reduce RA symptoms and disease progression. At this time, tocilizumab is the only drug that works by this mechanism. Also known as Actemra, is the first in its class interleukin-6 receptor antagonist. In 2010, the FDA approved Actemra for IV therapy of adults with moderate to severe active RA. However, owing to the risk for infection and other serious adverse effects, tocilizumab is indicated only for those patients with RA who have not responded adequately to other DMARDs. In 5 different clinical trials involving more than 4,000 patients, tocilizumab was significantly more effective than a placebo at reducing joint tenderness and swelling. Tocilizumab may be combined with methotrexate, but not with TNF inhibitors or other DMARDs that increase the risk for infection. In addition to the treatment of RA, it may also be received via the FDA's approval for the management of polyarticular juvenile idiopathic arthritis and systemic juvenile idiopathic arthritis. How does it work? Well, the drug is a monoclonal antibody that blocks receptors for interleukin-6, a pro-inflammatory cytokine that helps mediate the autoimmune attacks against the joints of patients with RA. By blocking interleukin-6 receptors, tocilizumab prevents interleukin-6 from promoting injury. Tocilizumab is the first drug to work by this mechanism. Adverse effects. Well, the most serious adverse effects are GI perforation, liver injury, and hematologic effects, neutropenia and thrombocytopenia. Other adverse effects include headache, nasopharyngitis, hypertension, and increased cholesterol levels. Serious infections. Owing to its immunosuppressant action, it increases the risk for life-threatening infections. Infections seen during clinical trials included tuberculosis, invasive fungal infections, and opportunistic infections caused by bacteria, viruses, protozoa, and other pathogens. Before starting tocilizumab, patients should be tested for latent TB and treated as indicated. During tocilizumab therapy, patients should be closely monitored for signs and symptoms of infection. In the event of certain lab changes, increased transaminase levels, reduced neutrophil count, or a reduced platelet count, tocilizumab should be given in a reduced dosage or discontinued, depending on the magnitude of the change. Treatment should be interrupted if the patient develops a serious infection. Which brings us to its black box warning. Tocilizumab may cause an increased risk for developing serious and potential fatal infections. Speaking of, we'll touch base real quick on its ability to cause GI perforation. During clinical trials, perforation of the colon occurred rarely. Most cases were complications of pre-existing diverticulitis. Patients at high risk for perforation, especially those with diverticulitis, should be monitored closely. Patients should be instructed to contact their prescriber if events of a severe persistent abdominal pain occur. Liver injury. Tocilizumab may cause liver injury, as indicated by the elevation of circulating liver transaminases. Tocilizumab should not be initiated if transaminase levels are more than 2 times the upper limit of normal. Transaminase levels should be monitored every 4 to 8 weeks during treatment, and if the levels exceed 5 times the ULN, or upper limit of normal, the medicine should be discontinued. Neutropenia and thrombocytopenia. Tocilizumab can reduce counts of neutrophils and platelets. Neutrophil reduction increases the risk for infection. In clinical trials, the reduction of platelets was not associated with increased bleeding. Neutrophil and platelet counts should be determined at baseline and every 4 to 8 weeks during treatment. Tocilizumab should not be initiated if the absolute neutrophil count is 2,000 or below, or if the platelet count is less than 100,000. Patients taking tocilizumab should discontinue the drug if the ANC falls below 500 or if the platelet count falls below 50,000. Other drug interactions. In general, tocilizumab should not be combined with other strong immunosuppressants, owing to an increased risk for serious infection. Anti-rheumatic drugs to avoid include the TNF antagonists, T-cell inhibitors, interleukin-1 antagonists, and drugs that block the CD20 antigen. Tocilizumab can reduce blood levels of other drugs. Under normal circumstances, interleukin-6 suppresses the activity of several cytochrome P450 drug metabolizing isoenzymes. By blocking receptors for interleukin-6, tocilizumab can negate the suppression and can thereby increase rates of drug metabolism. Drugs whose levels may be diminished include oral contraceptives, Coumadin, proton pump inhibitors, and HMG-CoA reductase inhibitors. Dosages for all of these agents may need to be increased. Anakinra, an interleukin-1 receptor antagonist. Anakinra, also known as Kineret, reduces symptoms of RA by blocking receptors for interleukin-1, a pro-inflammatory cytokine that plays a central role in synovial inflammation and joint destruction. The drug is indicated for patients with moderate to severe RA that has not responded to one or more non-biologic DMARD. It is also approved for the treatment of neonatal onset multisystem inflammatory disease. When administered, this drug, the solution should not be shaken, and the injection site should be rotated. Similar to other TNF antagonists, anakinra poses a risk for serious infection. Accordingly, the drug should not be given to a patient with an active infection and should be stopped if a serious infection develops. Both anakinra and TNF antagonists increase the infection risk. These drugs should not be combined. Which brings us to the prescribing and monitoring considerations for TNF antagonists. Patient education. Here's an excellent spot to hit pause so you can review some of the patient education that you would want to give your patients in regards to TNF inhibitors. For the most part, it'll talk about seeking medical attentions if there are symptoms of infection, skin rashes, bruising, bleeding, or pallor, heart failure, liver failure, things along that nature. So, therapeutic goal. TNF inhibitors are used to reduce symptoms and therefore delay disease progression in patients with moderate to severe RA. Identifying the high-risk patients, therefore. TNF inhibitors are contraindicated in patients with demyelinating disorders, which include heart failure, and active infections, which include TB and HBV. Exercise caution in patients who are immunosuppressed, such as HIV infections or on other immunosuppressant drugs, and in those patients who have diabetes, mild heart failure, liver dysfunction, latent TB, latent HBV infection, or a history of recurrent infections, and any condition that predisposes to acquiring an infection. Its administration considerations. Adalimumab, certolizumab, etanercept, and golimumab Teach patients and caregivers how to give a sub-Q injection using either a syringe or an auto-injector. Instruct patients to 1. Inject medication into the abdomen or the anterior thigh. Teach them to rotate the injection site, and teach them to avoid areas where the skin is tender, bruised, red, or indurated. Other ongoing monitoring and interventions. Tuberculin skin testing should be carried out before prescribing a TNF antagonist. A chest x-ray is actually recommended, especially for patients who will receive methotrexate. Baseline lab testing should include a CBC with a white blood cell differential, to be followed by a repeat analysis after the first month of therapy and every 3 to 6 months thereafter. LFTs should be included in a patient with a history of hepatic disease. A pregnancy test should be rolled out for women of childbearing age and for patients who are at risk for heart disease. A cardiologist consultation is recommended. Minimizing adverse effects are serious infections. Due to TNF's antagonist increase the risk for serious infection, including invasive fungal infections, reactivation of HPV infections, and infections caused by tuberculosis and other opportunistic pathogens, risk is increased by diabetes, HIV infection, and concurrent use of other immunosuppressant drugs. So in general, avoid TNF antagonists in patients with active infections, and closely monitor those who develop a new infection. Use caution in patients with a history of recurrent infection or any condition that predisposes them to acquiring infections. If a severe infection does develop, TNF antagonists need to be discontinued. To minimize the risk for TB, test patients for latent TB, and if the test is positive, treat for TB before starting TNF antagonists. During TNF antagonist treatment, monitor closely for development of TB. To minimize the risk for HPV reactivation, test for HPV before starting the TNF antagonist. Closely monitor your patient with a positive result. If reactivation of HPV infection does occur, stop the TNF antagonist and treat them with an antiviral drug. Allergic reactions. Rarely, TNF antagonists have been associated with severe allergic reactions, but they do include Stevens-Johnson syndrome, erythema multiforme, and TEN. So monitor for skin rashes and other dermatologic manifestations. Heart failure. TNF antagonists may cause new onset heart failure or may worsen existing heart failure. Exercise caution in patients who already have mild heart failure and monitor them closely for heart failure's progression. Avoid TNF antagonists in patients who have severe heart failure. Cancer. TNF antagonists may increase the risk for lymphoma and other malignancies, primarily in children, adolescents, and young adults. Patients and parents of children should be apprised of this risk. Hematologic disorders. TNF antagonists pose a risk for hematologic disorders, including neutropenia, thrombocytopenia, and aplastic anemia. If there is a significant hematologic abnormality or it has been diagnosed, discontinue the TNF antagonist. Liver injury. Rarely, TNF inhibitors have been associated with severe liver injury, but they do include acute liver failure. Some patients have required a liver transplant and have died. If severe liver injury is diagnosed, discontinue the TNF antagonist. Here's CNS demyelinating disorders. If TNF antagonists have been associated with rare cases of CNS demyelinating disorders, which include multiple sclerosis, myelitis, and optic neuritis. Avoid TNF antagonists in patients with pre-existing or recent onset demyelinating disorders. Injection site reactions to adalimumab, certolizumab, etanercept, and golimumab. Again, injection site reactions, redness, swelling, itching, and pain are common with these drugs. Infusion reactions to infliximab. Infusion reactions, those flu-like symptoms, headaches, fevers, chills, dyspnea, hypotension, skin reaction, GI disturbances are very common. To reduce those symptoms, pre-treat with an antihistamine, Tylenol, or a glucocorticoid. Manage mild reactions by slowing or interrupting the infusion. In the event of a severe reaction such as anaphylaxis, stop the infusion and do not use the medication again. Minimizing adverse interactions with immunosuppressants. Drugs that suppress the immune function increase the risk for infection. So again, use these with severe caution. And again, live virus vaccines. TNF antagonists may increase the risk for acquiring or transmitting infection after immunization with a live virus vaccine. Accordingly, live viruses and live virus vaccines should be avoided. And that concludes our chapter here for today. I thank you as always for listening, and I'll see you at the next chapter.